Hello, dental family. This is Dr. Johnson. Today we're going to be focusing in on a surgical extraction of tooth number 17. So, a couple things before we get started is that this tooth had a strong distal dilaceration in both roots, both mesial and distal root. So, you're going to see that. The assistant that I have with me today is a very experienced assistant. So, what we'll do is we'll focus in on what she's doing and how to get you guys caught up to speed. Here we go. Let's get started. All right, so again, tooth number 17. Tooth's not erupted too much out of the soft tissue or attached tissue. So what we're having to do is you can see that she's using both suctions to retract the cheek while suctioning. So you see she has the high volume working and the surgical suction working. I have my water very high because I don't like the smell of the burning tooth. Even though we're going to extract it and all that stuff, I still like to use a whole lot of water. Keep that tooth cool as much as possible. You see here, she's trying to reposition just again to make sure that I don't catch that soft tissue. She's doing a great job with an appropriate amount of suction. There we go, working our way through. Now this is tooth number 17, again on the lower left. Suppose the tooth was on the lower right, like a 32. What we'd be doing is the responsibilities would switch. I would be retracting the cheek, and she would be managing the tongue. Now I say managing the tongue because for those that have been an assistant before, I understand that the tongue has its own mind, and it wants to go wherever it wants to go. So you really want to try to control that suction, control the suction, and control the tongue. So now that I'm out, I'm switching burrs, but during this time, if this was a tooth that had a lot of blood in the area, what she'd be doing is rinsing out the tooth, making sure it's clean and clear of any blood clot, blood, saliva pool, anything like that. So now we're hopping back in. There we go. Perfect. Important handoff just happened right there. So we want to keep our patient safe and protected. Some offices will use a 2x2 like I just placed, or a 4x4. There's foam packs. There's a lot of different ways or a lot of different techniques and tools out there to help protect and isolate that tooth so that the patient can't aspirate or have any foreign bodies swallowed. So now here we are luxating and elevating. Again, her primary goal right now is just retraction, aiding or trying to increase the visual field of the tooth. So there's the distal portion of the crown. There we go. Again, she's retracting that cheek out of the way. She's also going in over the socket because there's a little bit of blood that's covering up the tooth. So now we just handed it off. There was a cotton forceps right there. That was the handoff happening off screen. Another handoff happening. Again, she knows what I want to go to next, and that's why these things are happening pretty quick. And that's eventually where we want all of the dental assistants to be. Some people like doing more extractions than others, and that's okay. But nonetheless, we want to be strong in every field and every discipline. So know your doctors, know what they like, know the sequences that they prefer, but also be flexible because sometimes things change. So here we are, we're doing a little bit more elevation and luxation on that tooth, on that mesial root. So we're working away. Again, she's just retracting that cheek out the way. And here it comes. Now another handoff just happened off screen. She took the straight luxator or elevator and handed me off the 151 forceps. I like the 151S, the pedo ones. I feel like I don't break as many crowns and root tips off with that. I get a little bit better control. So there it is. So this again is the mesial root. You can see the strong distal delaceration of the mesial root. And what we're looking at too is not just the curvature and the perfect split of that tooth. What we're focusing in on is the end of the root. So we saw there the apex was intact. Now we're back in the mouth. What we're doing is trying to get this distal root out. So we're just relieving a little bit of that bone around it. Now, if you saw here, when I'm out, she's in. So she's suctioning up any remaining water covering the socket, any blood that's covering the socket, and that hiding that last root tip down there. We're going to do this back and forth until I feel that we've relieved enough so that I can come back in with our next instrument and start luxating that root tip out of there. There she is. She's back in. Just taking our time. She's giving a lot of positive affirmation to the patient. Those are those soft skills that are kind of hard to teach in school, but it's imperative in a clinical setting. Patients have high anxiety a lot of the time when they come in, and it does help. Just affirming that they're doing a good job. You see here she's using her surgical suction, not to suction up any water or saliva, but actually to suck up the tongue and move it to get it out of the way, that we can have great visualization of that root tip. And there it is. That's the distal root. Also has a distal delaceration on it, as you can see. We're finishing off this case, wrapping it up, a little saline rich. Some doctors prefer to curette the site before this. The IAN was fairly close to this extraction, so we definitely didn't want to push too much pressure on that nerve, so I elected not to do that. So you see here, the mesial and the distal look great. They're clean and clear. We know we got the whole tooth. Patient had asked before the case began if I would close up this. We don't need to do it with every case, but it's still important to see here. Again, main thing that the assistant is focusing in on is retraction so that the doctor can see. There we go. We're just tightening it down. Some oral surgeons will ask their assistants to what's called follow, especially in the beginning portion of the sutures, and that's just holding the tag in so that the surgeon can keep nice consistent pressure as they do their throws for the suture. Now she's grabbing her scissors. I like to have a tag in somewhere around 5 millimeters or a centimeter, and then we just tuck it away. There we go. Awesome, perfect. So here's a couple takeaways that I want you guys to see here is her suction was perfect. It was adequate for the amount of aerosols being produced and saliva being produced. She also did a great job retracting the soft tissue and keeping it out of the way of the burr and preventing any damage. Remember, depending on the sites, the responsibilities change. You're not always just retracting the cheek. Sometimes you're in charge of retracting the tongue as well. Hope you got some great value out of this video. We look forward to seeing you, and we love you, dental family. Like and subscribe. Everything is down below. Check us out on our website as well. Look forward to seeing you. Take care.